here. So I'm very excited.
This is a special day. I mean, we really got people, we had to grab them and pull them in all kinds of directions, but we got them here, and I'm very excited as well. Hello.
I'm here.
Would you like to introduce yourself?
Hello, everyone. And Dr. Karim, it's this very special occasion. I've never met you, of course, and Jacob sort of introduced me to your work, and I'm really in awe of what you've done. I am a medical technologist by profession, so I worked all my life in the clinical lab, in the different departments of the clinical lab, biochemistry, hematology, bacteriology, blood bank. And so I just have a few questions for you today, but thank you for appearing in this podcast. It's really appreciated.
Yeah, of course. That will be wonderful, and I'm very, very excited to meet you. And thank you so much for sharing your questions and for reviewing our work. I think it's very important that we try to connect with you and with everyone, so that we can really make sure that we have a lot of information and collaboration on what steps can be next for treating our cancer patients.
That's great. And Dr. Karim, before we get into it, if you'd like to just share about, before you got into medicine, you're originally from Egypt, correct?
Yes, of course. Yes.
I'd love you to share just a little bit about that before we dive into to your profession and the study that you've been doing.
Sure. So I was born in Cairo, Egypt, and I grew up there. And my medical school was at the Faculty of Medicine, it's called Qasr Al-Aini. It's like one of the top programs, of course, in the area. And it was a lot of work, very extensive. And I enjoyed it very much. At the end of the day, I feel like, growing there and also working in the field of medical oncology over there did teach me so much, because diversity and knowledge about different places of the world and what the needs of patients are does make a lot of difference. I always aspired in working more in cancer research. So, of course, I'm very, very excited and happy to be here. I moved to the US in 2001 because I was really very impressed by the work of many scientists and clinicians as they build clinical trials and wanting to develop more treatments for cancer patients. So that's what I do right now. So I continued. It was also a lot of work, but along the road, I think we got the best out of the world. We got the place where we can learn from great leaders and great scientists, and at the same time going back and forth to connect with human beings in all over the world. So we got the best out of this world.
That's great. So as we dig right into it, you've been studying for a long time, and just to get right into it, just for the audience, so they can have just a two-part question, but a basic understanding. You're a thoracic medical oncologist, but before that, general oncologist.
No, I was also thoracic medical oncologist so you get trained in all fields, just of course to be able to be board certified or to go through the residency and the fellowship. So you train for more. But when I was in Egypt also, I finished the training and I was also a thoracic medical oncologist. So that was my primary focus. And then when I came here, of course, I did repeat the residency and the fellowship. And from the beginning also, the focus was about Phase 1 clinical trials, of course, was a focus, and prior to that and until now, developing newer approaches to treat the lung cancer and to treat, difficult to treat cancers as well.
Okay, so really quick for the audience to understand small cell lung cancer, could you break that down or explain that to the audience?
Yeah, so lung cancer is classified into non-small cell lung cancer, which contributes 85% of all lung cancers. And then there's the small cell lung cancer, which constitutes of 15% of lung cancer. So even though it's not the majority, but the significant piece of information that we need to know is small cell lung cancer is the most aggressive amongst all types of lung cancer. So even though it's 15%, it needed a lot of work because it is for a very long time, it has been treated for, with a standard of care treatment. And until recently, of course, incorporation of immunotherapy made, of course, a little bit of a difference that we need more out of it. But small cell lung cancer tends to divide quickly and to go and involve different areas of the body. So not only stay in the lung, but it has propensity to spread to the brain or to the liver or to other organs. And at the same time, if left untreated, it can affect, lives of patients. It is also a difficult to treat disease. It can respond very well to the first-line treatment, so response rate is good. But the problem is that even though that it would respond, but it tends to recur and it tends to progress.
And just so everybody understands, you're the director of developmental therapeutics at Inova Scar Cancer Institute, correct?
Yes.
And professor of medicine at the University of Virginia School of Medicine, correct?
Yes.
Could you now share the recent study that was presented at the American Society of Clinical Oncologists, the 2023 annual meeting called the SWOG S1929 study?
Yes, it was presented in June at the ASCO, and that study basically focuses on small cell lung cancer patients who from the beginning have what is called extensive stage disease. Extensive stage disease means that it is not localized. It's because if it is localized to just the lungs, we treat that with chemoradiation. But if it is extensive, it needs chemotherapy plus immunotherapy, which has been the standard of care. So within the S1929, patients are receiving first the chemotherapy and the immunotherapy. And then after that, during that time, we check them for a specific marker on their cancer cells. It's called Schlafen 11. It's maybe difficult to repeat again, but it's called Schlafen 11. And it was proven that this Schlafen 11 from previous studies has, of course, more than like around half of the patients with small cell lung cancer do have that marker. And that marker actually can predict the response to some classes of anti-cancer drugs called like PARP inhibitors. So it's a new drug. It's called talazoparib. So because these patients can respond better to this specific type of drugs or class of drugs, those patients were selected to be recruited for the study. So after they finish the chemoimmunotherapy, which is standard of care, they get to be randomized either to continue standard of care, atezolizumab, which is the immunotherapy, or to receive that same atezolizumab standard of care plus a new drug called talazoparib, which is the PARP inhibitor. And remember, those patients are all Schlafen 11 positive. So in that study, we looked into how long it will take them to progress. So even though it was more like close to like a month longer, but of course, in the world of oncology, if you prolong the time until the disease progresses for a month, that's that is significant because it's better to have a month, or it was 1.2 months longer. So that's better because what we have presented, it was 2.8 months in the standard of care and 4.2 months and then what we did after that is just like we continue to follow them because it was only 5 months. So we're going to look into the levels of Schlafen-11 to correlate it with the clinical outcomes. So hopefully that will have more information in the coming few weeks that we can report as well.
Now that's amazing. This is Scarcy. I want to jump in here, Dr. Karim. Nice to meet you as well.
Thanks.
One of the questions I had for you, for myself, that I just came up with on my own was like, how many clinical trials have you been in, and have you seen any positive forms of prevention as a result of these trials?
Yeah, of course. So like from the older days, like 1996 and so on, we were part of one study, which for small cell lung cancer, also it was topotecan. It's really old drug, but it became FDA approved after that. But then, of course, we want to improve this. There were better drugs that were studied after and became FDA approved, and it's not the end, because it's a very difficult disease. So even if we prolong the time until disease progresses, or if we prolong survival, we still need more, more work and more treatments. Because if we do those more treatments, it's going to be better. It's just going to be better. So I was involved in so many studies, and we'll go from there. I think that, I can't count them, but I'd say that I started being involved in the studies since the year 1996 or so.
Okay, so it's safe to say you've had a ton of trials that you've been a part of.
Yeah, yeah, that's very true.
Absolutely. And then one other question, and I'll hand it back to Jacob. So in terms of the second opinion, how important is that to get a second opinion when someone actually has been diagnosed with cancer? How important is that to your patients?
So there are pros and cons for that. Of course, the pros is good because sometimes if you go somewhere else where they have clinical trials or novel treatments, or sometimes you need more guidance or more information. The problem is I would not suggest to delay treatment so much for going for too many second opinions. Because the reason is because if there is a standard of care, especially for first line, it's known amongst oncologists. And it's important to, especially for small cell lung cancer, not to delay the treatment, because otherwise, if left untreated, it's short time, for survival. So that's why we do encourage our patients to start treatment and not to have a lot of delay. If it's not delaying treatment, of course, it is reasonable to see what else can be offered.
Right, and that I guess that would be considered some of the pros, but what would you say is some of the cons?
Yeah, the cons would be that we don't want to delay treatment. If someone is, of course, going to too many appointments, by the time they are getting to the last appointment and they go back to their first doctor to see them, sometimes the disease becomes like more aggressive if it's left untreated for a long time. So it's the time factor also is very important. So of course, you want to have opinions, that's good, but it's not good if we impact the care by delaying the initiation of treatment.
Hey there, from All Emotion, this is Jake. I want to say thank you for taking the time listening to this episode. Just make sure to please check out our website, allemotionpodcast.com, YouTube channel, Spotify, and many more. And again, thank you for listening to All Motion.
Okay, I'm sorry. Dr. Karim, this is Irene Harrison, and I'd like to ask a few questions. When you're trying to diagnose specifically small cell lung cancer, what are your initial tests? Are you alerted when the blood tests come back? And what do you see, especially with the hematology test? What do you see that may indicate the small cell lung cancer?
So it is, of course, the pathology. That's why I was saying, if you're in one center, yes, of course, the pathologist will call us if it's within the hospital. But it's so important that patients know if they do have a biopsy to follow up and bring the information to their treating oncologist if it's not in the same hospital. Because we do know the results when someone gets a biopsy from the tissue, from the tumor itself. When they get that piece, pathology can say that this is small cell lung cancer. There will be blood tests that we do that just, see the blood counts and, liver, kidney functions, or if there are bulk of disease like serum LDH or, things like that, or serum uric acid if you're looking at tumor lysis. But for small cell lung cancer diagnosis itself, you need to have to do it by pathology. And of course, this should be in the patient's chart. The next generation sequencing or more genetic information, so far it doesn't guide treatment for small cell lung cancer. So circling back, it's the tissue diagnosis that is important here.
Okay, thank you.
Yeah.
So initially, I guess by the time the pathologist has pretty much diagnosed this, then the case is sent to you as a specialist. So if a patient initially, what symptoms would he be exhibiting? What would I initially do? Am I gonna have a persistent cough? And that's what's going to send me to my primary care physician, and then my primary care physician will order blood tests and maybe, of course, x-rays. And what are they going to see that's going to say, oh my gosh, this is really serious?
Yeah, so patients who have pneumonias that, come like 2 or 3 pneumonias, that recurrent pneumonias, they should be, of course, screened. That's number one. Number two, patients in general, which is, I would say, the lung cancer screening. Unfortunately, it doesn't capture everybody, but it can capture quite a bit for patients above 50 years of age that have smoked one pack a day for 30 years or for 20 years, or for 20 years, with other conditions that have, for example, chronic obstructive lung disease like asthma or COPD. There is a screening. There's annual screening that should go hand in hand with tobacco cessation. Like we tell people to stop smoking. If someone has coughing blood, basically they are having weight loss, any of those symptoms, when they go, basically they will go to the primary care physician because they don't go to the oncologist first, and then they will obtain something called CT scan of the chest. The lung cancer screening is done through a low dose CT because it has less exposure to radiation, because they do it like every year. But basically, the CT scan can show the tumors more. The X-ray can show the tumor, but it can show larger tumors. So that's why the CT scan is more helpful in detecting nodules.
Okay, thank you. And just to hone in on that, I'm very interested in the hematology aspect of diagnosing the small cell. If I am having the symptoms that you described, the coughing, constant coughing, pneumonia, reoccurring. And I go to my primary care, and the primary care doctor has blood taken. When the in the lab, it goes to the lab, and the hematology department is going to run a CBC, do a differential. What's gonna show up for small cell lung cancer?
So far, small cell lung cancer does not get diagnosed for blood. It gets diagnosed through the tissue. There could be research, of course, looking into maybe predictive biomarkers, but it's not yet the standard of care. So in the blood, it's going to show more if someone has like liver problems, so if they have liver problems, that can be translated that maybe they have the cancer spread to their liver, or maybe they have something called elevated LDH, which means that they have a high burden of disease. So these are all like correlatives, but for the exact diagnosis for small cell lung cancer, so far in 2023, it's still based on the tissue diagnosis. Of course, looking into, the markers, we looked into the F1929 study for Schlafen-11, if it's going to be done in the blood later or so on. That also is going to be a correlative, but that's a way to go later to choose therapies. So not yet. We're not there yet. So hopefully that can be something in the future.
Okay, thank you. And my last question is, as far as science knows to date, or can prove to date, is this cancer, is it caused by smoking or exacerbated by smoking? How far is science, has science progressed so that they can say more than likely this small cell cancer was caused or exacerbated by the fact that this patient is a lifelong smoker? Thank you.
So no, this is good, because we want to emphasize that small cell lung cancer, majority of patients are smokers. Very, very rare that we can find a small cell lung cancer coming in a patient who is a never smoker. It can happen, but it's very rare. But small cell lung cancer usually happens in smokers, and that's why it is very, very essential to propagate the piece of information for not to start smoking, and if someone started smoking, to quit. To have specific markers to say that one person is having a cancer that is related to the smoking, you possibly can see through the imaging. Of course, if there, a lot of times that someone has a chronic obstructive lung disease. Clinically, of course, those patients would have the carbon dioxide level. Of course, the oxygen level can be affected by smoking, but not in the pathology that the pathology will detect cancer cells with a smoking level or so on. However, we do know as a fact that majority of small cell lung cancer is basically found in smokers. So not all smokers are going to develop small cell lung cancer, but most of the small cell lung cancers are from smokers, if that makes sense.
Yes, it does. And I thought of another question as you were speaking. It's very interesting. You were born in the Middle East, in Egypt, and I'm just curious, and I'm sure you have knowledge of other parts of the world. Is small cell lung cancer, are there hot spots around the world, or do you know? And where are they?
Yeah, I did hear about, there could be areas that have more small cell, more than others. We don't really have a way actually to have specific numbers so far. So you do have prevalence, We don't have like incidents in different places of the world. And actually, even here in the US, we wanted to do some studies to see the location and zip code and things like that, but it was not possible, especially that people move from a place to another in many circumstances. So that's why it's not easy to put those information about pockets of areas with small cell lung cancer. But I think it's important to learn about, where and if there's work environment or home environment that has other factors, because remember, there's information about radon or information about patients not having enough aeration or any of passive smoking. All these things still are not benign. So.
And have you seen any cases where, again, environmental, where patients live where the air quality is really bad for respiratory illnesses?
There was a presentation at ESMO, which is European Society of Oncology, and it did link. It wasn't small cell lung cancer. It was EGFR, which is another subtype of non-small cell lung cancer, and they did actually link air pollution to this subtype of lung cancer, which is the EGFR positive. So there is actually information that pollution can cause specific types of lung cancer. It's called EGFR.
Okay. Well, thank you.
There were data also like women, like that's in China, when they have like the deep fried food, the air out of it, when it comes to their lungs, the lungs, inhale that, and it can cause also EGFR positive lung cancer.
Interesting. Well, thank you very much. It's all very interesting, and I wish you luck in continuing the very important research you're doing. Thank you.
Sure. Thank you so much.
So just to jump in here, just to veggie back off of Ms. Harrison's question, I know that there was a study that's unrelated to cancer, that there was a study that was done by a doctor in Florida who was studying about postpartum depression. And what she yielded from the results she yielded from that study was that women that are surrounded by trees, about 76% of them did not face postpartum depression. So that's very interesting when we talk about environmental conditions and things like that can affect the internal pathology and the immune system overall. So that's very interesting. So I have one more question, and then I'll hand it back to Jacob. I know we have a little bit of time left, probably about 10 minutes. So I'm in technology. Part of why I got into technology is because of the advancements of technology. Outside of personal vaccines and cell therapy, gene editing, so on and so forth, what are some of the technologies that you're aware of in terms of the ability to be able to prevent cancer from spreading and from developing, and more of a proactive method?
So you mean that technology can act in making an intervention to prevent smoking?
Right, like not smoking, but I'm saying cancer overall, even if that is from research, right? Because the technology, nanotechnology, has the ability to do studies, and the answers with artificial intelligence and machine learning are so fast that there are technologies that our research is, sped up by, 1,000%. So I was just asking if you're aware of the marriage of technology and science, and if there are any new developments that you're aware of from a technology standpoint.
So we just had a symposium this past weekend that we did include artificial intelligence, and our colleagues from Cornell and from other major institutions and the NCI and and all, and it was very important that, of course, when we do a clinical trial, that we utilize the technology like the artificial intelligence or our colleagues from radiology to help with, better assessments for that. But my problem here is that it's not mature yet. Like, it still needs some work before this becomes standard and approachable and reachable for everybody. As regard using the technology to prevent the cancer, you can use you can use basically the social media or more of those techniques to let people know about not to smoke, or to avoid radon, to avoid dangerous situations, so that they do not get exposed to cancerous etiologies. And at the same exact time, that also we can share with them where to go for care, or if there are specific studies, clinical trials, information about treatments. They have patient support groups. There are now a lot of patient advocates and support groups that can even share with each other, any of the side effects, any of the problems. So I think this is important.
Sure. And I'm aware of like robotic surgery and like crayon electron technology. And I know that when we use in information technology and forensics, we use artificial intelligence for research and detection. So, I'm sure I'm going to keep my eye on that. Hopefully we'll get you back for a second interview at some point. But I want to say thank you again. And thank you to Ms. Harrison for being here as well. And thank you very much, Doctor.
Thank you.
Dr. Karim, it's Jacob again. And no, I appreciate your time. I have one or two last questions, and what I wanted to touch on is Schleffen 11 gene. Could you break that down for the audience a little bit? Because when I read about it, I have a basic understanding, but how that, and I know it was a study done with 2 control groups, correct?
Correct. Yes. Right. So Schleffen 11 is basically a protein. So it's not a gene, it's a protein. And in humans, it's encoded by the Schleffen 11 gene. But what we detect is the protein on the tumor cells itself. And so, of course, the Schleffen 11 gene, it encodes or makes like a family of 11 different proteins. One of them, which we mentioned, it makes basically a correlation that these patients have, there is a DNA damaging agent, which is a drug, that these group of patients who are going to express this protein, the Schleffen 11, are going to be vulnerable, or are going to have their tumor sensitive to respond, or to shrink, or to get better outcome when treated with specific agents. And these specific chemotherapies can be like a cisplatin or carboplatin, or could be the talazap or the PARP inhibitors, or even the radiation. So it just attracts our attention that this group of patients are going to have more benefit if treated with these specific drugs or radiation, or so on. For the clinical trial, we used this protein when we stained the tissue of the patients, which didn't take long time. It was a median 7 days. So from 2 to 3 days to like maybe a little bit longer, but median was 7 days. So it was feasible. So the study was important because it showed that small cell lung cancer can be like non-small cell lung cancer, or could be like other types of cancers, where we can use some markers to help us know which patients can respond to which drug better. That's it.
No, I appreciate that. And Ms. Harrison or Scarcity to see if they have any last questions. And again, thank you so much for your time. Well, what I wanted to know, how could we? Yes, we can end in 2 minutes. One last question, and I'll turn it over, and we can end for sure. How could people be better educated about cancer in general?
So I think, one of the important things that we need to learn is that we should do something called primary prevention. So primary prevention is to not to get exposed to components that can trigger cancer. So basically, it's not a good idea to start smoking. Make sure that the teenagers are aware of that. So that's number one. Maybe, if there are situations, if people are, working in factories or in specific areas, to make sure that the workers are safe and they test their exposures, or basically try to have, areas that have less exposure to, even for radiation, like doctors, even, or technicians who work in the hospital, if they are exposed to radiation, to make sure they always have, parameters, and they give them off actually if they are exposed too much to the radiation. So these are all primary prevention. Secondary prevention is that we do have cancer screening programs, basically for colorectal cancers, for lung cancer right now, with the specific criteria, if there's colorectal cancer, cervical cancer, skin cancer. So these are secondary prevention. So these will detect the cancer when it's so small, so the surgeons can take it out, and we are able to prevent them from, having significant disease when detecting the cancer in early stages. Then there's tertiary prevention. So tertiary prevention means that even if the patient has a more advanced disease, that we take care of them and provide them with the best opportunities for medications and therapies, so that we have a better quality of life, and things would work well.
Thank you so much. And Ms. Harrison in Scar City, she has to run, but do you have anything, last closing questions or comments before Dr. Karim has to leave?
I just want to say thank you again for joining and thank you for your time.
And again, thank you, Dr. Karim, for being here. It's very informative. Yes.
Thank you very much. It was my pleasure.
Thank you, Dr. Karim. And really quickly, if there's anybody that wanted to reach you, if it's, I know you're very busy, I wouldn't give your information out, but if there was, how could someone reach you, or not maybe reach you, but reach, get in contact with you or potentially other colleagues?
Yeah, definitely. It will be through Innovashar Cancer Institute, our phase 1 program. That's they can definitely reach our phase 1 program, and we can do our best to help them and offer any I would say feasible studies that would, as long as patients meet the eligibility criteria, and seen and evaluated, and this is something that would be considered for them. Our staff would really support in doing that.
All right, Dr. Karim, I thank you so much for your time and being flexible. We've been trying to sit down since May. So thank you so much again. I know you have to go. So thank you so much for your time. I really do appreciate it. And we'll follow up with you offline about when we put everything together and when we publish the episode.
Sure. Thank you so much. Thanks.
Thank you.
Bye.
Have a great day.
Thank you, Dr. Karim. Thank you.
Thank you. Thanks. Bye.
Thank you.